Hello, everyone, and welcome to Do Your Part to Care for Your Heart, presented by Inspira Health Spirit of Women program in partnership with Cardiac Partners at Cooper and Inspira. Thank you for joining us this evening. My name is Matt Brown, and I'm the Assistant Vice President of our Cardiology, Pulmonary, and Neuroscience service lines, and also your moderator for today's program. Before we get started, I have a few housekeeping items I'd like to cover. Please note, the information shared is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Secondly, we as panelists are unable to see or hear you in our Zoom platform. Attendees will remain muted and off camera throughout the duration of our program. Now, please refer to the Q&A tab located at the bottom of your screen. Here you may submit your questions as they will be answered at the conclusion of our program. Your question will be visible to the panelists, so if you would like to remain anonymous, please check the box ensuring so. Poll questions will appear on your screen during the presentation. We encourage your participation as we engage in a lively atmosphere. And lastly, a recording of today's presentation will be provided to you in a follow-up email this week. Also included in this email is a survey for your completion, as we value your feedback. I'd now like to introduce you to our speakers for today. First, we have Dr. Kurt Callback. Dr. Callback is an interventional cardiologist with Inspira Medical Group Cardiology in Mullica Hill and a member provider with Cardiac Partners at Cooper and Inspira. Dr. Callback completed his medical degree, residency in internal medicine, and fellowship in cardiovascular disease and interventional cardiology at Hahnemann University Hospital. Dr. Callback is the clinical director of Network Cardiovascular Services for Inspira Health Network, co-medical director of the Cardiac Catheterization Laboratory at Inspira Medical Center Mullica Hill, and serves on the Cardiac Partners Board of Directors. Dr. Callback, thank you for joining us this evening.
Matt, it's my pleasure. Thank you for having me.
Next, we have Dr. Robert Ocasio. Dr. Ocasio is a primary care provider with Inspira Medical Group West Effort and a clinical assistant professor with Rowan University School of Osteopathic Medicine and Inspira Health's internal medicine residency program. Dr. Ocasio completed his medical degree at Universidad Central del Caribe, Puerto Rico, and residency in internal medicine at Cooper University Healthcare. Dr. Ocasio, thank you for joining us.
Thank you so much. It's an honor for me to be part of this program to increase awareness of women's health. Thank you.
Great. Next, we have Dr. Lohitha Raghupathi. Dr. Raghupathi is a clinical cardiologist at Cooper University Healthcare and a member provider with Cardiac Partners at Cooper and Inspira. Dr. Raghupathi completed her medical degree at Icahn School of Medicine at Mount Sinai and her residency in internal medicine and fellowship in cardiology at Thomas Jefferson University Hospital. Dr. Raghupathi serves as the Associate Director for the Structural Heart Program at Cooper University Healthcare. Dr. Raghupathi, thank you for joining us this evening.
Thank you, Matt. It's a pleasure to be with everyone today, and I look forward to speaking with everyone on this topic.
And finally, we have Dr. Jean Gay. Dr. Gay is a structural and interventional cardiologist with Inspira Medical Group Cardiology in Mullica Hill and a member provider with Cardiac Partners at Cooper and Inspira. Dr. Gay began his medical education at Universidad Autónoma de Guadalajara, ultimately completing his medical degree at New York Medical College. He then completed his residency in internal medicine and fellowship in cardiovascular disease and interventional cardiology at Cooper University Healthcare. Dr. Gay, thank you for joining us this evening.
Greetings, everyone, and thank you for allowing me to participate and to share with you guys some of those knowledge that we acquired along these years.
Great. Thank you so much. So Dr. Callback, before we get into our topic for this evening, are you able to tell us a little bit about the Cardiac Partners relationship that Inspira has with Cooper University Healthcare and really what this partnership means for the patients within our community?
I'd love to, Matt. Thank you. Cooper University Healthcare and Inspira Health have brought together cardiac services from both organizations to form a collaborative we call Cardiac Partners at Cooper and Inspira. The affiliation was established over 4 years ago, January 2018, and has provided patients in South Jersey with access to a more coordinated and comprehensive form of cardiac services across the entire continuum of care. The combination of the two systems' heart services makes Cardiac Partners the largest cardiac program in South Jersey, with a network of more than 65 clinicians. It's an innovative delivery care model that provides patients with better access and more efficient, high-quality cardiac care in more locations throughout southern New Jersey. The point of all that is to make sure that cardiac experts are available in lots of locations across South Jersey, that we can provide coordinated care from diagnosis to minimally invasive procedures to advanced cardiac surgery and cardiac rehab, while allowing you to remain with your provider of choice, who will help guide you through the plan of care and make sure that you receive the most appropriate care at the most appropriate setting based on your individual needs.
That's great. Thank you for that background, Dr. Callback. So with our topic of doing your part to care for your heart, our panelists will go through some healthy tips for preventing as well as managing disease so you can still live a normal lifestyle. I'd like to first start with a poll question to gauge the audience. This is a yes or no question. You'll see on your screen the poll will pop up. So just answer yes or no, and the results will come through to us. Do you or anyone in your family have a history of cardiovascular disease? I see some people are sharing in the chat. Jenna, I don't know if the poll is coming up. Okay, perfect. All right, so we do have some responses that came through the chat. If you do want to just answer, right in the chat, you can do so. Overwhelmingly, I think everyone is responding back yes. I think so, yes. So I think with that response, I believe everyone here recognizes the impact that cardiovascular disease has on our community. So I'd like to start with Dr. Ocasio. Are you able to give the audience a brief overview of the circulatory system and some tips for keeping it healthy?
Of course, of course. So we'll start with the basics. Circulatory system, it's three different systems, basically, the heart, the lungs, and you have arteries and veins of all shapes and size working together to deliver blood filled with oxygen and nutrients to the cells, so the cells do the vital processes and the tissues and organs. So that's the basics. We're not going to go into details, but basically, if some of these arteries get blocked or the process gets blocked, that's when we encounter one of these cardiovascular emergencies. For example, if it happens in the coronary arteries, you get angina or you get a heart attack. If it happens in your brain, you get a stroke. Or if it happens in your limbs and your extremities, you may get some gangrene, or you may get some vital tissue damage. So that's why it's important to know the circulatory system and how it works. Next slide. And then when we talk about the cardiovascular system and how, what are the things that we could do? There's many things, and most of these things we know. The first one, and one of the biggest risks is smoking. So we tell, if you never smoke, don't start. If you smoke, try to quit as soon as you can. It's never too late to quit. To maintain a healthy weight, and there are some studies showing that healthy BMI is less than 25. There are other factors that we're not going to go into detail, and also maintaining a waist circumference less than 35. They have done studies in women and men higher than 35. There is an increased risk of cardiovascular disease. And then we talk about the exercise, minimum amount of 30 minutes a day as a base, and then eating healthy, low-fat diet, low cholesterol, high in fruits and vegetables. The diet that has been prescribed the most is, or recommended the most, is the Mediterranean diet. There's a lot of studies regarding cardiovascular and the Mediterranean diet. And then avoiding trans and saturated fats, processed foods, fast food, limited alcohol use or alcohol intake. Watch your salt intake, because that will raise your blood pressure or make you retain some fluid. And very important, reducing the level of stress in your life. All these things will help maintaining a good circulatory system.
So those are some great tips, Dr. Ocasio. Are there any common cardiovascular risk factors in women? And are you also able to walk us through some common problems with the circulatory system, which we're trying to prevent with these healthy habits that you mentioned?
Yes, absolutely. So before I talk about the specific common risks for women, I want to mention the traditional ones, the traditional risks. Age, as we get older, there's an increased risk of cardiovascular disease, atherosclerosis, tobacco use, high cholesterol, hypertension, diabetes, and family history of coronary artery disease. That goes for everyone. Those are the most well known. But then in women, you need to be aware of like pregnancy complications. If you were diagnosed with gestational diabetes, it's known that gestational diabetes carries a 25% increased risk of cardiovascular disease, women that have been diagnosed with that, and 70% of women with gestational diabetes get diagnosed with diabetes type 2 later in life. Preeclampsia is another big one. And that one is hypertension while you're pregnant and affecting some organs. Usually preeclampsia goes away after pregnancy or improves, but you still may carry a twofold risk of cardiovascular disease by just being diagnosed by that with that condition. Polycystic ovary syndrome, you might have heard about that. There are different types of them, but the ones that carry the most risk for cardiovascular disease will be the one with increased androgen, and the ones that develop insulin resistance. The androgen is the type of hormone that is similar to testosterone. It carries a risk of hardening the arteries and increasing your risk of cardiovascular disease. Along with that is early menopause, which is described as having a menopause in early 40s. As you probably know, once you hit a menopause, it drops, your estrogen production drops drastically, but your ovaries still produce a small amount of testosterone, and that testosterone continues, even though small. That also is an androgen like substance that affects your vessels. Parity has been studied, and women that have more than 5 live birth also have a risk of cardiovascular risk in the future. And then we need to mention about hormone replacement. If you've been on hormone replacement after menopause or perimenopause, or have been on oral contraceptives, there is a slight risk. Again, these are risk enhancers. These are not absolute risks. These are things that you need to know to talk to your cardiologist, talk to your primary care. And to finish, there are autoimmune conditions that affect women the most. Lupus and rheumatoid arthritis, those cause inflammatory reactions, and they're also known to increase cardiovascular risk later in life. And then the stress, depression, obesity, and sedentary life, all those together also increase the risk of developing hypertension, insulin resistance, and diabetes in the future. If you could have the next slide. And then we mentioned these. So these are that was to your second question. These are the most common problems that we see: high blood pressure, coronary artery disease, and heart attack. Coronary artery disease, we're going to talk about that, but that's basically when there is plaque formation in your arteries. And the heart attack is when that gets completely blocked and the tissue gets affected. Heart failure, stroke, aneurysm, and peripheral artery disease. Those are the most common conditions that we see, or sometimes we refer to a cardiologist, but I'm not going to get ahead of my game here.
Oh, I think that's great. Thank you for that, Dr. Ocasio. So you started to mention about referring to a specialist like a cardiologist. What types of these conditions may be treated under your care? And can you tell us a little bit about when a cardiologist may become involved?
Okay. Yes. Yeah. So basically, a lot of these we try to do, prevention, obviously, because we're primary care. So we do treat, hypertension, try to prevent, complications from hypertension. We do treat early peripheral vascular disease or prevent them by treating cholesterol. We do treat, diabetes, which we mentioned. And then when we identify conditions like, chest pain, either chest pains or angina-like symptoms, or we call PVCs or palpitations, obviously arrhythmias like AFib or tachycardias, and those are the and peripheral vascular disease. Those are the conditions that we refer to patients. But sometimes we do echocardiograms, in those echocardiograms we find valvular disease or structural disease, and we do tend to refer the patients early, and that's the key word. We try to do it as early as possible.
That's great. Thank you. Thank you for walking us through that. So that'll move us to our next poll question. So speaking of being referred to a cardiologist, and again, this should pop right up on your screen. So it's another yes or no question. Have you ever been referred to or visited a cardiologist prior to this webinar? You should be able to answer right there on the screen. Give it a second for some responses to come through. All right, so it looks like we're about 50-50. So about half were yes, that they have been referred to or visited a cardiologist, and the other half were no. So thank you for that. So turning it over to Dr. Callback, are you able to tell us what to expect if we as a patient are referred over to cardiology from our primary care provider, and also tell us about how our PCP will stay informed of any treatment that's done?
Yeah, Matt, that's a great question, and is important for everyone to know, whether you're a patient or a family member of a patient. Whether you're being seen by one of the cardiologists at Cooper University Healthcare or at Inspira, you should know that you're going to have a seamless experience when you're being referred to that provider's office from your primary care physician. We collaborate in the care of most of the disease processes that we identify. Some, of course, has to be taken care of specifically by the cardiologist. but we share as much of the responsibility as we can. Our electronic health records allow us to communicate information and message one another in real time. So you should always feel confident that once that referral has been made, that the referring provider will have access to the data that we gather and our opinions about what needs to be done to improve your health in a really a real-time fashion.
That's great. That sounds like a great collaboration. So Dr. Ocasio mentioned some of those common problem areas within the circulatory system. Are you able to go into a little more detail around some of those and what types of treatments one may expect?
Yeah, sure, Matt. Was it, high blood pressure, Rob spoke about. Both primary care providers and cardiologists are well-versed in taking care of your blood pressure. So many problems can occur if you're not taking care of your blood pressure, and you don't really realize you're having the problem related to high blood pressure until something tragic happens, like a stroke, or you find out that you've got significant kidney problems, or that you've developed an aneurysm, or perhaps a level of coronary artery disease or a weak heart muscle. We're looking for blood pressure control at 120 for the upper number, the systolic blood pressure, and 80 or less for the lower number, or the diastolic blood pressure. That doesn't guarantee that you're not going to develop problems, but we have seen in the literature very clearly that maintaining a blood pressure of 120 over 80 or better significantly lowers your risk of so many of the cardiovascular problems that we've already mentioned. Let me see the next slide. Great. We talk about hardening of the arteries, or cholesterol plaque getting deposited in your arteries. That plaque can make the arteries stiff, so your blood pressure rises. It can also cause an obstruction of blood flow through the arteries, which can cause angina, or cause you to be at risk for having a stroke, or develop symptoms in your legs when you walk that we refer to as claudication. Can also cause your kidneys to not function properly, and of course that leads to problems clearing waste products from your body, which can lead to some tragic consequences, such as the need to be on dialysis or have metabolic problems related to the kidney disease. Smoking is the single most important risk factor for those problems that you as a patient have control over. We really don't have drug therapies that manage the consequences of smoking. You really need to quit smoking as quickly as you can. And as Dr. Ocasio said early, if you never smoked, don't start.
Great.
Next slide, please. Oh, coronary artery disease. As an interventional cardiologist, this is a lot of what I deal with, and what all of us as cardiologists deal with. When that plaque develops in your arteries to the point that it's restricting blood flow, you're going to develop symptoms. And the point of talented primary care providers like Dr. Ocasio is to recognize that the problem may be developing before it creates problems for you. We would much rather deal with treating it or managing coronary artery disease before you have an urgent or emergent problem, such as a heart attack or unstable angina. The pain or heaviness in your chest, that is the symptom associated with your heart not getting enough oxygen. Heart failure or congestive heart failure occurs by multiple mechanisms. We try to divide heart failure into categories where your heart muscle performance is compromised or weakened. And then there are also forms of congestive heart failure when your heart is functioning okay, or at least it's contracting properly. The management of those problems is sometimes specific to the disease process that's causing the problem. For example, if you have a blocked artery causing your heart muscle not to perform well, we want to unblock the artery with a balloon or a stent or bypass surgery. But there are several medications that have been developed over the last 30 or 40 years since I've been in medicine that go a long way toward managing the consequences of having a weak heart muscle, and may ultimately also help to improve the efficiency of the heart. Next slide, Matt, please. Peripheral artery disease or peripheral vascular disease are the problems typically in the legs that limit the blood supply to the buttocks or the thighs or the calves, and create symptoms when you spend too much time on your feet, or at least more time on your feet than your blood supply can handle. When symptoms like that develop and aren't managed early enough, they can lead to problems getting enough blood supply to the tissues of your legs, even at rest, and you can develop ulcerations of your skin and wounds that have a tough time healing. You know, again, this is a problem that we'd like to diagnose early and manage early before it creates problems that can lead to significant health consequences that might require intravenous antibiotics or amputation. Next slide, please. The same cardiovascular disease, the same cholesterol plaque deposits that can occur in the arteries to your heart or the arteries to your legs can occur in the arteries to your brain, small vessels or large vessels. With stroke being such a significant cause of death and disability in the United States, we want to be able to manage your risk for having those problems by managing the risk factors that Dr. Ocasio talked about, and intervene when necessary, when we get beyond the point where medications alone are going to do the job. And we have some really neat things that we can do to help under circumstances before you're having a stroke. And we even have opportunities to help you in the middle of having a stroke with some very talented neurointerventionalists at Cooper University Hospital. All right, heart attack is Dr. Gay's and my bread and butter as interventional cardiologists. We're available, the two of us and another 5 of our colleagues at Cooper and Inspira, plus some other talented physicians working out of the Inspira Vineland facility and at Cooper. If you're having a heart attack and you show up at one of our hospitals, we are going to be able to take you directly to the heart catheterization lab and open up the blocked artery with balloons and stents and some very good drug therapies to dissolve blood clots, try to stop the heart attack before it does any permanent damage, or at least limit the amount of permanent damage that happens. You know, everyone's heard the classic stories of an elephant on someone's chest that won't go away and is associated with nausea and shortness of breath and getting sweaty. But we have to remember that women in particular can have some unusual symptoms of a heart attack or of an impending heart attack.
Thank you for that, Dr. Callback. And for going through all those. I want to touch on that last point that you mentioned. So you said that women may experience heart attacks a little bit differently. Are you able to dive into that a little bit further?
Sure. You know, the classic symptoms are the classic symptoms, and most women are going to have the same symptoms that men have, but unusual symptoms such as extreme fatigue, a sense of being tired that you don't understand, problems breathing that weren't present a short time ago, unexplained nausea, even vomiting, or other GI-like symptoms, indigestion and heartburn, or symptoms in unusual places like your neck or your jaw or your middle of your back. symptoms, any of those symptoms occurring with physical activity and going away with rest or improving with rest should alert you that they may be related to heart disease. Or anytime the classic treatment for heartburn or indigestion or mild nausea doesn't work, you should be thinking that perhaps it's your heart causing the problem and seek medical attention early.
That's great. Thank you for that. So I'm now going to jump into another poll question. This should, again, pop right up on your screen. Just true or false question. And it's touching on that last point that Dr. Callback mentioned. So men and women are likely to experience similar symptoms of a heart attack. True or false? Couple seconds. So it looks like we are about 50-50. And now that I'm reading back at my wording and something that Dr. Callback said, so yes,
Yeah,
they are
Matt.
likely to experience similar symptoms, but I think there are some others, that Dr. Callback mentioned. It looks like you're jumping in.
Yeah. Yeah, Matt, I think though that's exactly the right mix of answers. There are some unusual symptoms for women, more likely to occur in women than men, but the vast majority of heart attack symptoms are going to be similar for both men and women. That heaviness in the chest and that I mentioned. So I think we got the point across. I don't think that's a point of confusion.
That's great. Thank you so much. And thank you, Dr. Ocasio. So I'd now like to turn to the second part of our discussion around structural heart health. So Dr. Raghupathi, are you able to tell us a little bit about what it means when someone says structural heart disease?
Yeah, absolutely. So here's our slide on this. So when we talk about structural heart disease, what we're really talking about is, in contrast to coronary artery disease, which Dr. Callback touched on, we're talking about disease affecting the actual anatomy of the heart, the valves, the chambers, the walls of the heart. And the reason, one of the reasons we define it this way is because over the last 10 to 15 years, we've had a lot of advances in how we can treat this type of these types of heart conditions. So we kind of lump together all of these possible conditions that we can treat in a non-invasive way under the umbrella of structural heart disease. So some examples are on the slide. So valves that don't close or open properly. So what we're talking about is aortic stenosis, mitral regurgitation. So stenosis meaning, when I tell patients about valves of the heart, the way that I like to explain it is valves are kind of like doors between the chambers of the heart. So the doors of the between the chambers, when functioning properly, kind of close and open smoothly, and they completely close. And when there's a problem with the valves, then sometimes what happens is the door doesn't either open properly and it obstructs blood flow, or it does not close properly and lets blood to go backwards, which is what we call regurgitation. So some other examples, so abnormal openings between the chambers of the heart. So for example, an abnormal connection between the right and left side of the heart would be a atrial septal defect or a ventricular septal defect, depending on which two chambers are being connected. And there's also a area in one particular part of the heart called the left atrium, which is kind of analogous to the appendix in that its function is somewhat limited. It's called the left atrial appendage. It's kind of a little pocket in that left atrium. And in patients who have one particular type of abnormal heart rhythm, it can cause more than 90% of strokes. So that's an area that we are able to address with a non-invasive procedure. So we kind of put that under the category of structural heart disease.
That's great. Thank you for that background. Are you able to let us know some of the common structural heart procedures that may be used to treat some of these issues?
Yes, definitely. So at Cardiac Partners, we offer a variety of options to treat structural heart disease. So some of the issues which I had just mentioned are listed here on the slide. So we'll start with the top one is repairing an atrial septal defect. So this is that abnormal connection between the right and the left atrium. It can be closed in a non-invasive way, meaning through catheters without open heart surgery. We can close this defect. So if you look on the right side of the screen, there are some pictures here. So this is kind of just an illustration of the hole, the connection between the two atria, the right and left atria. And you can see here a device that's being deployed to kind of sandwich that hole and close off the defect. And this can be done through a catheter. Somewhat similar to that is closing a patent foramen ovale, which is not exactly a hole per se, but it is a small flap connection between the right and left sides of the heart also. And in certain patients, it could be responsible for causing a stroke. So certain stroke patients are candidates for having this also closed, which is another procedure that we offer. So for the third bullet on here is about the mitra clip. So this is a catheter-based technique to repair mitral regurgitation, so a leaky mitral valve. So it is the device that you see on the bottom right of the screen. It's kind of a small clip that we deliver through a catheter up into the heart and basically clip leaflets of the mitral valve that are moving abnormally in order to treat mitral regurgitation.
That's great. Thank you so much for that. So for this slide, we'll bring in Dr. Gay. So Dr. Gay, are you able to walk us through a couple more of these procedures, and then also talk a little bit about which ones you may be able to perform?
Yes. Thank you very much, Matt. Of course, we can discuss some of this procedure. So the balloon valvuloplasty, one of the heart valvular problem that we just discussed, which is like for mitral stenosis, meaning that like Dr. Raghupathi just mentioned, it's like having a door that's not opening completely. So basically blood trying to rush through the door, but it's not opening. So basically like blood just stay in one chamber, cannot go to the next chamber. So basically your body needs the blood. So you're gonna feel the symptoms of not receiving blood. It's just having like someone with anemia, but the body has the blood, but it cannot go where it's supposed to be. So what that does is you just put a balloon through that door, and you open the balloon and you open the valve. So basically that's exactly what that does. This is like something like usually we can do for a mitral valve itself. The next procedure we see here, it's a left atrial appendage closure device. So we have two devices that can be used, a Watchman and amulet. So let's go back to atrial fibrillation. So atrial fibrillation, like it's one of the most common arrhythmia we treat in the hospital. Like you can see, like they call us all the time. So, especially in the setting of COVID-19. So what that tells us, atrial fibrillation mostly affects older people, mostly. Basically, if you go to 60, 70, those people are gonna have, let's say if you're like 60 and above, 4% of those people are gonna have atrial fibrillation. And you get to 80 years old, those people like 9% of people above the age of 80 will have atrial fibrillation. Why is it important? So atrial fibrillation, like Dr. Raghupathi just mentioned about that little pocket you have in the heart, which is like in the atrium, you have that little pouch where it's there. So when your heart is fibrillating, meaning like the atrium is not beating anymore, it's just like shaking. So blood goes into that hole, like that little pocket, and then stay there. So you form clot. So that's why when you have irregular heartbeat, atrial fibrillation, we put you on blood thinners. But I just said people with AFib tend to be older. So older people tend to tend to have a lot of bleeding risk. So those people, putting them on blood thinner put them at risk for having a major bleeding, and that major bleeding can be detrimental. So hence, that's why those devices were invented. So the reason we do that, so once we put the device, it's minimally invasive. So we go from the groin, we go from the a vein, and we go all the way to the right heart, and then we go across, and we deployed that amulet device or Watchman device. And once we do so, this patient will be able to get off the blood thinner. And by plugging those pockets, that we reduce the risk of having a stroke. So you don't need the blood thinner, and the risk of bleeding from a fall and all that will be lower. So that's talking about the Watchman or amulet device. The next device is what we call the transcatheter aortic valve replacement. So aortic stenosis, which is again, the aortic valve is the main valve that opens up so that the heart can push blood to your body. So basically to your brain, to your arms, to your liver, to your kidneys, to your lower extremities, to your genitalia, blood has to get there. If that door does not open, what's going to happen? So if there's an open, blood doesn't go to your brain. So you're going to pass out. That's one of the symptoms of a bad aortic valve. The next thing going to happen is, if it's not opening up, so the heart going to get congested. And because of the congestion, the wall going to increase, and you're going to have like some chest pain, because like the artery, the plumbing of the heart are not getting filled with blood. So you're going to have pain in your chest, like you're having a heart attack. The other thing is, it's not pushing forward, the blood going to go back. Because remember, your heart has the left and the right side. The blood goes from your heart to the body and comes back to the right side. From the right side, it pumps into your lungs. And the lungs get oxygen and goes to the left side, and the left side pump it again to your body. So if the left side is not pumping forward, what's going to happen? So the blood going to go back to your lungs. Guess what? If the blood stays in your lung, you cannot breathe. So if you cannot breathe, you're going to come to the hospital with shortness of breath, and you're going to come with heart failure. So that's one of the things aortic valve stenosis can give you. So heart failure, chest pain, heart failure, passing out. So what do we know about aortic valve stenosis? Once you develop the symptoms, most studies show you have 6 months to up to 2 years, 50% of those people will not do well, meaning that 50% of this patient will die in between five months to 2 years. So it's important when the symptoms start happening, before they start happening, you should see Dr. Ocasio, who will see that and will send you to a cardiologist, and we can follow that, because our objective is to prevent that from getting worse. And once they get to that point, we can go minimally invasively deploy a valve to a transcatheter, because before we only could do that by opening your chest. And most patients in their 80s did not qualify for this type of surgery, because they're older, the risk of, a mortality was high. But nowadays, 80, 90 years old, we can deploy a new valve and you can go home the next day. This is why we do that.
That's great. Thank you both so much for that information. And your last point there kind of leads me into my next question to you two. If are you able to walk us through the typical process if a patient may be a candidate for one of these structural heart procedures, and the coordination of care between cardiac partner sites at both Cooper and Inspira? Dr. Raghupathi, if you would like to start, and then Dr. Gay, if there's anything else to add, you can jump in as well.
Yes, sure. Yeah. So, I see patients primarily through Cooper. Dr. Gay sees the patients at Inspira Hospital. But so what we will end up doing is what first happens is the patient may get referred to a regular cardiologist, a clinical cardiologist, by their primary care doctor. So someone like Dr. Ocasio, whoever is your primary care doctor, is often the first person to pick up that there's something wrong here. You have a murmur, for example, and you've been experiencing some shortness of breath, and they pick up that there's an issue that needs to be evaluated further. So then the patient would go and see a general cardiologist. What we would do is start off with ordering some testing, figure out, for example, get an echocardiogram. So just to take the example of someone who suppose they have aortic stenosis. So we do the echocardiogram and we pick up severe aortic stenosis. And then the clinical cardiologist will be the one who kind of considers, would this be a right person who would require open heart surgery, or would they be someone who benefits from a structural heart minimally invasive procedure to replace their aortic valve? Then they would be sent to a structural heart specialist. So the structural heart specialist would then evaluate the patient and see if they would need, what type of testing they would need prior to a procedure. So for example, prior to a aortic valve replacement, you may need a heart catheterization. You may need a CAT scan to look at that aortic valve and look at the anatomy of it, to decide on sizing the valve and several other technical aspects of whether a minimally invasive TAVR valve would be appropriate. So this pre-procedure testing, we kind of work together to have it done at a site closest to you. And then ultimately, once kind of all the ducks are in a row and we make the decision, the clinical cardiologist in combination with the structural heart specialist that, this is the right procedure for this patient, then we have a team of people who we work with. So not just the cardiologist, but nurses, nurse practitioners, folks who are involved in scheduling. So we have a team of people who will coordinate with the patient in order to schedule this procedure and have it performed at Cooper University Hospital by the structural heart specialists. So, after the procedure itself is done, as with all things in cardiology, it's everything requires follow-up. So we are, for example, the patient may get a new aortic valve, and then they would require a follow-up echocardiogram to keep an eye on that valve, see how it's doing, and some follow-up testing also, which can be done at a variety of cardiac partners facilities. So that's kind of a brief overview. I went through it using the example of a aortic stenosis and transcatheter valve replacement. So I'll hand it off to Dr. Gay, who may be able to speak to the process with patients coming through the Inspira system.
Thank you very much, Dr. Raghupathi. I think it's the same flow that we have. So basically, patient will come from a PCP or from the hospital. They will refer them to our clinical cardiologist, and in their office. And, that sometimes they would just, like send me a message, say, hey, we have a patient here. We think that, will benefit, from a consultation from you for like either for left atrial appendage coach device, or, like a PFO or something like a TAVR. So the next thing will be like making sure that patient, really qualify, for such procedure, meaning like you just, Dr. Raghupathi just mentioned, we have to make sure that it's, it's truly severe aortic stenosis, look at the symptoms. And the next step will be like for us to do cardiac catheterization, making sure the reason we do cardiac catheterization is because we want to make sure that there is no coronary heart disease, meaning that let's say if you have coronary heart disease and you have heart disease, so basically we can ask the surgeon, hey, listen, if the patient need a valve, can you do a bypass surgery, during that operation? And in a setting of, if you need a left atrial appendage, in a setting of AFib and atrial fibrillation, irregular heartbeat, and a patient with high risk of bleeding or falls, that those patients can get what we call a TEE, which is like an ultrasound, or we do from like an endoscopy. You just basically go down the foot pipe, we take a look at the appendage, making sure there's no clot, we do some measurement. And, with that, then we will get our coordinator, which is like, they're pretty good. They stay on top of our patients, like, they make sure everything is scheduled well. So the next step will be for the TAVR to see a cardiothoracic surgeon. And after the cardiothoracic surgeon will see you, usually Dr. Bowen will see you at Cooper Hospital. And if you qualify for, minimally invasive procedure, then we'll get a CAT scan at that time. If they think you need open heart surgery, then no CAT scan is indicated. So basically, you also go ahead and do the surgery. The reason we do a CAT scan is because we have to measure not only the heart valve to see like what type of valve we're gonna put. We have to see the anatomy of like measure all the vessels in your body, making sure like the catheter we're gonna use can go through those blood vessels. Remember, if your aortic valve is calcified, that means you're gonna have some arteries in your body also that will be very calcified. So we have to measure it, making sure like it's safe to do so. So that's what we do. After we do the procedure, the TAVR, we see you in our office in Molecular Hill. And if you from Cooper, they see you like in one of the Cooper facility, and we send you back to your clinical cardiologist and to your primary care doctor.
That's great. Thank you both so much for walking us through that. So I am going to jump to, and really quickly, the last poll question will pop up on your screen. Structural heart disease affects the heart's anatomy, such as valves, chambers, walls, and pockets. True or false? So quickly, we'll go through that, and then we will go through some takeaways and move on to Q&A. So just as a reminder, at the bottom of your screen is the Q&A where you'll be able to ask questions. So that is true, and everyone got it right. So great job. All right. So, at this time, I'd like to bring back in Dr. Ocasio to recap some of the major takeaways for our audience when it comes to the circulatory system health, and then Dr. Raghupathi and Dr. Gay for any final thoughts on structural heart disease.
Thank you, Matt. So in 3 words, takeaways: prevention, early detection, and early referral. So most of these conditions, you may not experience any symptoms like high cholesterol, hypertension, as we discussed. So it is important to detect them early and prevent the life-threatening conditions that may happen in the future that will be harder to fix or put your life at risk. So I think that's the main takeaway. And also, if you develop symptoms, especially women with different conditions and symptoms that you may develop, just make sure you tell someone, make sure you tell your primary care physician, the physician that you have the relationship. But even if you are seeing a cardiologist, make sure that you tell him or her all your past medical history, even if you feel that it's not relevant. And I'll leave it to
Great.
Dr. Raghupathi.
Dr. Raghupathi or Dr. Gay, any final thoughts on structural heart disease?
Just that, I think that it's been very exciting to work in this field with a lot of rapid advancement in the technology. So we're able to do things now that we weren't able to do in the past. And so, I think working together with the primary care doctors and finding out who are the right candidates for this is something that, we continue to do on a day-to-day basis. And, we just wanted to provide some information on this to you guys today.
That's great. Thank you so much. All right. So again, before we get into some questions from the audience, which again, at the bottom of your screen is the Q&A function. But Dr. Callback, and I know we went through a lot of the services provided through Cardiac Partners, but if there's any on here that you would like to touch on, if not, we will then get into some Q&A.
Yeah, Matt, it's an awfully long list on the screen. We do just about everything that is needed in the management of acute and chronic cardiovascular conditions. So I would encourage anyone who feels either in primary care or in clinical cardiology or any patient on their own that feels that they have the need to have themselves evaluated for some form of cardiovascular disease. Cooper and Inspira through the Cardiac Partners program have all of the tools in the tool belt that are needed.
That's great. Thank you. All right, so we will now go into any questions from the audience. So if you haven't had a chance to submit any questions and would like to do so, feel free, again, right at the bottom of your screen is the Q&A button, to submit a question. And we do have one that's come in so far. Does blood pressure rise with age? Anyone on the panel like to start with that? Dr. Ocasio or Dr. Callback, I saw you come off mute.
Yeah, I've always got something to say, Matt. We talked earlier about atherosclerosis, or the cholesterol plaque developing the arteries can cause them to stiffen and cause the blood pressure to rise. So it doesn't mean we want that to happen. So I think the answer to the question is you're more likely to develop elevation in your blood pressure as you get older, but the standards that we hold for normal blood pressure are the same whether you're 40 or 80.
That's great. Thank you so much. Any other questions that have come through? So I think we probably have time for one more question. So here's one. My father has struggled with high blood pressure and cholesterol issues, despite a pretty healthy lifestyle. Fortunately, I'm in my mid-30s and haven't had those issues yet. Is that reason enough to see a cardiologist at some point? So actually, I'll start with Dr. Ocasio.
Yes. So if your father had high blood pressure, being treated for that, and high cholesterol, but no what we call premature coronary artery disease, and you are in your 30s and your blood pressures are normal and your cholesterols are relatively normal, roughly, I would say at this point right now, you may not need to see a cardiologist. But again, you have to probably sit down with your primary care and calculate your relative risk, cardiovascular risk in the future. And there are different calculators, although you are too young for that calculator. Usually we start at age 40. That may give you some hints whether you need to see a cardiologist or whether you need to be more aggressive. But it looks like you are doing the right thing in terms of staying active and monitoring your blood pressure and cholesterol. Welcome, any of the cardiologists to add on to that.
Yeah, Rob, I think if you're absolutely right to say that you should sit down with your primary care provider who, is the point person for looking at your risk factors for any disease process, cardiovascular or otherwise. And if there's any need to go beyond the primary care provider to manage your blood pressure and manage your cholesterol or calculate your risk, the cardiologists at Cardiac Partners are happy to help.
That's great. Thank you both so much. Oh,
And that's one thing that I have to second, that the communication between the primary care, cardiology, and other specialties is it's alive, it's immediate. So with Cerner, so that's the advantage of being in the system, and I bet it's also similar with Cardiac Partners.
That's great. Thank you so much. All right. So, I just want to thank all of our speakers. Thank you guys for joining and you're providing all the information that you have, as well as our team behind the scenes. Jenna and Suzanne, thank you guys so much. So as a reminder, a recording of today's presentation will be provided to you in a follow-up email this week. And also included is a survey that we kindly ask for your participation, as we value your feedback. And before we close, I'd like to spread the word, that Inspira Health is about to embark on a network-wide cardiac enhancement strategy to elevate and expand its cardiology services. The foundation is preparing to launch the All Heart, the campaign for Inspira Health, to engage the philanthropic partnership of those we serve and help make this expansion a reality for our community, ultimately enabling Inspira to provide life-saving care for people closer to home. So be on the lookout for more to come there. And on behalf of our speakers, I want to thank you all for joining us this evening. We hope you were all able to find this information useful, and have a great rest of your week. Thank you, everyone.
Thank you.
Thank you, Matt.
Thank you.
A pleasure.
Thank you.